Hi friends, today's topic is drug resistance in mycobacterium tuberculosis. Whenever we diagnose a patient with tuberculosis, be it pulmonary tuberculosis or extrapulmonary tuberculosis, we do some investigation like sputum smear for acid-fast bacilli and CB-NAT. We don't do culture routinely, but in the beginning itself, if CB-NAT is done, then we can get the resistance and susceptibility report, whether the patient is susceptible, the mycobacterium tuberculosis is susceptible to rifampicin and isoniazid, or whether this bacteria is resistant to these drugs. Now, those facilities where CB-NAT is not available and the patient is put on treatment on the basis of sputum smear examination, then we have to diagnose it in the follow-up. Patient usually they come for follow-up in regular interval. Usually after first 2 months, after the initial treatment, the intensive phase, then patient comes for follow-up. That time we do sputum smear examination and we see whether the patient has turned negative for mycobacterium tuberculosis. If the patient is negative in sputum smear, that means a patient is responding to treatment. Then there is no question of resistance, and we don't suspect that. If the patient is positive in the follow-up, then we should suspect this resistance. It is possible that patient is in the beginning itself patient is attacked by a resistant bacteria, or during the treatment, if the patient is not taking the treatment properly, I mean regular medication, then patient can develop this resistance. So in the follow-up, we do sputum smear and we suspect whether the patient is having resistance or not. And then we ask for culture. Routinely we do no culture. Then the mycobacterium is grown in culture, and after that drug susceptibility test is done. Now in drug sensitivity test, all the drugs are done, then we can decide what are the drugs patient is susceptible or not, or resistant. According to that we can plan. During the follow-up, we can do chest X-ray PAVO, and we can look for clinical improvement also, so that we can judge whether the patient is improving or not. The clinical symptoms, what the patient was earlier having, whether it has subsided or not. Now, if the patient is already diagnosed as resistant tuberculosis, then patient and patient family member should be counseled, and they should know that this is a bad tuberculosis. A patient who is diagnosed as tuberculosis for the first time is put on primary drugs, and if he is cured, then well and good. This is very good because the primary drugs are less toxic and easily available, they are less costlier, and you can say they are cheaper actually, and patient will be cured with 6 months. So primary drugs, if the patient is treated by primary drugs like that, there is no problem at all. But if the patient is having resistant tuberculosis, then we have to do that culture and all regular interval. Then the drugs are costly, they are toxic, they are having lots of bad effects on different organs of the body. So patient should know the bad prognosis and the possibilities of resistant tuberculosis and how the treatment goes on. So primary drugs are good, and we will try to get a better cure and better prognosis in a patient with primary drugs. Friends, these are the things regarding drug resistant tuberculosis. I will be coming with a lot more videos on drug resistant tuberculosis, the treatment and all. But here I have just given a little clue and very little information regarding the drug resistant tuberculosis. Thank you. watching this video and stay healthy.